We're at 12:30. We will go ahead and get started. I know there will be more people joining, but I want to have plenty of time. I want to have plenty of time for our didactic and our case discussion. So let's get started. So welcome to Project Echo Geriatrics. I'm Kate Bennett. I'm a geriatrician based over at Harborview and with our Northwest Geriatrics Workforce Enhancement Center and the medical director of Project Echo geriatrics, not the whole thing. And I am really excited about our talk today. So we'll run this session like we usually do. We start off with a brief didactic that's about 15 minutes on a primary care geriatrics topic. And then we'll get into a case discussion. And I don't see our case presenter on yet, but I know he'll be joining. So we have a great case to discuss. I'm going to introduce our speaker who's familiar to many of you, Dr. Leigh Ann Mike, who is a clinical associate professor and the assistant director for outreach in the Plains Center, assistant director for education. And she is expert in everything related to geriatric pharmacology, has a ton of clinical experience, and always gives great advice. And today she's going to be talking to us about an article related to the Beers criteria, because what often happens with the Beers criteria of meds we're supposed to try to avoid is what do we do if we avoid a medication? What do we do instead? And that's what this article is all about. And Dr. Mike is going to walk us through that. So thanks so much for talking to us today, and I'll let you take it from here.
Great. Thank you so much for that introduction. It's good to see some familiar names on the screen. Um, Happy to be here to talk about this today. If you could please confirm that you can see my slides.
We can see the slides, but it's not the presentation view. It's
Okay. How about that?
that looks perfect. Thanks so
Okay,
much.
all right, let's get going. Thank you so much. I aim to use my short 15 minutes to pack as much in as I can. So we won't be able to cover the entire article, but I hope to highlight a number of useful tools that you can use from within. So given that we have a short time, I've reduced our objectives to just a couple. And the first one is to review the Beers criteria themselves, just so we can understand how this new alternatives article can help us and be complementary to the Beers criteria. So we'll start out with a short review of the actual Beers criteria, and then we'll talk about the new article that outlines alternatives to those. Because I think, as Dr. Bennett mentioned, it's hard to know what to do when you have one tool that just says avoid, don't do something. We're like, okay, then what are we supposed to do? All right, so a couple of comments just from my pharmacist lens. And you could see that I've taken the liberty of reorganizing the age-friendly diagram to show how medications is more closely related to all of the M's. So as a pharmacist, of course, we focus a lot on medications, but we need to do it through the lens of it affects mobility, it affects mentation, and what matters can affect our other choices. So the four M's applies. I just wanted to put it through slightly different perspectives. So, from my pharmacist lens, you can see how things might be interrelated. So why are medications such an important part of the four M's? Well, we know that older adults have many comorbidities. Can take many medications. An older adult's response to medications can change with age. And as a result of that, you're more likely to have adverse drug reactions or potentially drug interactions. And then we'll talk a little bit about deprescribing toward the end, but one method of managing these kind of issues is through deprescribing, which can reduce medication burden and enhance safety. And as I sort of hinted at the beginning, medications in fact impact the other three M's. So there's a lot of safety reasons why we really want to pay attention to medications. And to that end, we use there are a number of tools that can help us identify potentially unsafe or potentially inappropriate medications. One of the tools is the Beers criteria, but it is not the only tool. And you can see that this is an article, this is the most recent update from 2023. So the Beers criteria, the AGS Beers criteria are updated at regular intervals, the most recent one being 2023. Um, Interesting, the Beers criteria have been around since 1991, pretty long time. And the original goal was to identify medications that had harms that outweighed the benefits, and it was primarily intended for use in a nursing home setting. But, we're like, well, older adults live outside of that setting, and these are good recommendations for all, so let's expand these recommendations to all older adults. And then in 2010, the American Geriatric Society took over the stewardship of the Beers criteria and it updates regularly. Kind of alongside that, a list of alternatives was first published in 2015. So to get at the point of, well, we know we shouldn't be using certain drugs, but what could we use instead? So the very first list of alternatives was published in 2015, and that hasn't been updated until now. And so that will be what we'll talk about toward the latter half of this. So just to make sure we're all on the same page, really the idea behind the Beers criteria is that we want to reduce older adults' exposure to potentially inappropriate medications. This can be used as a tool for education, and it can be used as a tool to evaluate for quality of care and things like that. And as I mentioned earlier, that these criteria can be applied to all older adults across care settings, with the exception of hospice and end-of-life care. So really, it's a very all-encompassing. For those of you familiar with the Beers criteria, you would recognize that they have lots of tables, and they are organized into 5 categories. And I've put the categories here just to refresh your memory. So it's essentially a list of medications. And if you are, trying to use this reference, it may be a little bit challenging to find the medication you're looking for because it's not necessarily obviously or apparently clear from the get-go what table you should look in to see your medication. But, as you get familiar with the tool and you can use it more, you have a sense for what's where. So just as an example, for example, the medications that might be considered potentially inappropriate would be things like aspirin for primary prevention. Medications that are inappropriate for certain conditions might include things like avoiding benzos in somebody who has a history of fall or fracture. Using with caution could be including things like the risk of urogenital infections with the use of SGLT2 agents. Drug-drug interactions, examples include opioid plus gabapentin, and then adjusting for renal dysfunction, so gabapentin and famotidine. Now, this is not all-encompassing. It's just meant to give you a sense for what's included in each of the tables. All right. Let's see. So this is what the table in the Beers criteria looks like. And you can see that it's kind of organized by category, by organ system, by condition. And it gives you a list of medications. And then the next column tells you the reason why it's potentially inappropriate or less safe. And then the recommendation is pretty sparse and it just says avoid, 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 avoid. And then it tells you what the level and quality of quality and strength of recommendation is. So, to the point that was raised earlier, it's kind of hard to know what to do if the end is just avoid. And I guess it's worth noting that avoid means something specific in particular for Beers criteria. So it doesn't mean that you should absolutely not use it ever. It just means that you should generally avoid it unless there's a particular reason, unusual circumstances, for example, when a safer alternative didn't achieve the desired outcome. So the idea is that my medications on the Beers criteria are not never used. that they could be used under certain circumstances with appropriate monitoring and after careful consideration of risk and benefit. So don't walk out of this thinking that nobody should ever be on a Beers criteria medication. There may be circumstances and situations where that may be appropriate. Okay. So, where does that leave us if we've got a list of medications that basically tells us just to avoid them? How do we manage that in clinical practice? Um, well, with the new guidelines or the new article that just came out, the idea behind it was to offer some guidance on treatment strategies for common conditions. And the list of medications that was put into this article is drawn from the Beers criteria. So it's meant to be used complementary and used in concert. Um, the other thing that is intended to do is offer some pharmacologic and non-pharmacologic interventions that may be used in place of. So it gives you something that you can do. Um, Additionally, what I really appreciate about this new article is that it gives lots of resources. And it's resources for clinicians who are working with patients and caregivers to make a clinical decision, but it also include resources for patients and caregivers so they can kind of learn about what's happening and kind of be involved in those care decisions and go in fully informed. And these resources are intended to help support the implementation of any particular treatment strategy that's chosen. And then in terms of the format, it's organized by clinical condition or symptom. So it, I think, offers a little bit more ease of use than the 5 giant tables that are in the Beers criteria. So let's take a look at what that looks like. Again, because we don't have time to talk about every single table, I wanted to show you a couple of different examples of what it looks like and what some of the resources look like. So to give you a sense for how you might use how you might use this tool. But before I do that, just a reminder that there are particular principles behind using these alternatives. And I think probably the most important thing, which is probably why it's rated number one, is that the goal is not just to stop a medication. The goal is to help people feel better using pharmacologic or non-pharmacologic methods, help them feel better, maintain their health, and reduce their risk of harm. So remember, your end goal is not to just stop the medication. And again, I've mentioned already, like number two is that non-pharmacologic strategies can be really, really useful and appropriate, and so should be factored into the decision making. And then number three is a reminder that sometimes symptoms need a little bit more investigation to understand what's causing them, because those causes may be amenable to additional treatments rather than just pharmacologic management of a particular symptom. And as always, these recommendations don't take the place of, expert clinical judgment and shared decision making with patients. And then lastly, I'll show you a couple of resources and supports. All right, so with the alternatives, it is broken down into 5 tables, real similar to Beers, but you can see that it offers a little bit more guidance so you can more easily navigate to the table that you're looking for in looking for symptoms. So I think the very first category is pretty self-explanatory about what would be included in there. Under the cardiovascular conditions, it includes things like anticoagulation, rate control for atrial fibrillation, heart failure, hypertension. Under the central nervous system and neuropsychiatric category, that includes things like insomnia, anxiety, delirium, Parkinson's disease, and tardive dyskinesia. Under gastrointestinal conditions, that includes GERD, gastroparesis, cramping and diarrhea and constipation. And then under genitourinary, that includes nocturia, the genitourinary syndrome of menopause, and recurrent UTIs in women. So really helpful if you know what system or condition you're looking for to navigate. So let's take a look at a couple of examples. The first one I've chosen is to share is insomnia. And so you can see it's similar to the way Beers criteria is laid out. In the first column is the symptom or condition, and then the second column is the list of medications with the recommendation that is to avoid all of them. And if you remember how the Beers criteria was, it sort of ended there, avoid. This one, you can see there's actually quite a lengthy list of considerations to factor into your decision-making process. And it follows the principles that I shared a couple of slides ago. So, for example, with insomnia, hey, maybe instead of just managing or stopping a medication, let's take a look and see if there are other factors that are affecting sleep, such as pain or other medications or sleep apnea or things like that. Let's assess what might be causing this or contributing to it and see if we can address that, if something is there. Also, it includes non-pharmacologic treatment options, including things like cognitive behavioral therapy for insomnia, and then kind of goes down the list, non-pharmacologic. And then if medications may be necessary, there's a list of medications to consider, but also there's also some caution in terms of like the level of evidence or the amount of evidence to recommend or not recommend particular medication. So it gives you a number of treatment options to consider and discuss with patients and their caregivers. And then on the far right screen, you can see there's a list of resources, and you can see it's broken down by resources for patients and their caregivers or for clinicians. Now, I have to admit, I haven't checked out all of these links yet. I'm slowly working my way through, and I would recommend the same for you. So as you're working with somebody with insomnia, kind of check out some of the resources that are available. It can help you become more familiar with the list. But you can see, for example, in the patient one, there's some apps that they could potentially use for kind of self-management of, they got the insomnia coach, the Sleep Easy Digital, CBTI, things like that. And then for clinicians, there's a little bit more kind of guideline type of information. So that's one. The second example I've chosen for you is anxiety symptoms. And again, it's organized exactly the same way. And if we were to focus on the middle column with the considerations, again, it reminds us to clarify whether these symptoms are related to an underlying psychiatric disorder and to consider what else may be contributing to these anxiety symptoms, because those things may be amenable to other treatment strategies and approaches, which include things like group or individual therapy, cognitive behavioral therapy, different types of therapy. And then also, if pharmacologic therapy is indicated, it kind of lists out what some potential options might be. So again, a very much more comprehensive approach toward managing anxiety symptoms rather than just avoid benzos or avoid, Z drugs. And on the right, resources again for patients and caregivers. I wanted to show you a little bit about what a couple of the resources look like to give you a sense for, if you were to click on one of these links, what would happen. So if you were to click on the link for the deprescribing the patient resources, and for those of you who want to kind of do this alongside with me, I put the QR code at the bottom. It will take you directly to that site. This takes you to the deprescribing, the Canadian group's deprescribing information, and this is very robust website that includes lots and lots and lots of information that's for clinicians and for patients and caregivers. And they have patient brochures that can help you. You can give this to a patient and they can kind of go through it. And within the one for sedative hypnotics, there's a quiz to see, to test a patient's knowledge of their medications. There's a patient testimonial of somebody who had been on benzos for a long time and had fallen and talked about her journey to kind of come off benzos. And so there's a lot of helpful tips, and it's framed in a way that is helpful for families and patients to think about how they might, want to enter into a shared decision or a treatment plan to come off the benzos. And you can see that at least on the screen, there's two additional ones, but if you were actually on the website, there's a bunch more of educational materials that are written in very patient-friendly language. So those are there for you to kind of navigate. And then for the clinician side, right, if you're working with a patient and you're deciding to kind of taper down benzos, this gives you some considerations or a suggested plan for how to do that. So it does talk about a slow taper, understanding what's happening, determining whether this really is something that should be done. And then on the flip side, there's some information about how to engage patients and caregivers, how you might taper down a dose, how you might include some of the other non-pharmacologic options available. So if you were to kind of do this with each of the different symptoms or conditions in there, you would see that it's kind of an entire treatment plan, and it's giving you helpful resources across different ways. So as a clinician, you can see the more technical aspects of how you might kind of go through your clinical thought process and arrive at a decision, and then complementary talk with the patient and their caregivers about how you could work together to make that happen. So I mean, my sense is this is a really robust, person-centered way of kind of coming up with shared decisions to avoid potentially inappropriate, potentially unsafe medications. I think I wanted to give you my assessment after having spent a little bit time with it of this, and that is that I think this tool is really intriguing and beneficial. It was developed by an interprofessional panel that includes psychologists, physicians, nurses, pharmacists, physical therapists. So a lot of people from a lot of different perspectives. And within the panelists, they included both generalists and those with some clinical specialty or expertise to help guide the recommendations. The recommendations were not based off of a formal literature review, so you didn't see any um, strength of evidence and quality. You didn't see any ratings like that. It was more like this group got together and they pulled clinical practice guidelines, best practice guidelines, and literature summary that were relevant to older adults to frame their recommendations. So I like find it really practical, useful, and it offers that sort of answer to that question of, well, if I'm supposed to avoid it, then what do I do next? So I think it really helpful with that. And then again, the resources for clinicians and patients. A few of the limitations I kind of observed, and maybe there would be more to share from the group, but I think some of the recommendations are not quite as applicable outside of an ambulatory care setting, which is, that's okay. And most of the callers, and most people on the call today are in an ambulatory care setting, so hopefully this will be really helpful for you. The other thing is that the list is not comprehensive, so it does not include all conditions that older adults may experience. It's really kind of pulling from the Beers criteria list. So if you're looking for something comprehensive, this is not going to be that for you. And though even though the panelists did a job, did their due diligence in crafting guidelines, there are still gaps in the literature. For example, there may not be a sufficient amount of evidence to make a particular recommendation in terms of medications for an older adult, just simply because of the gaps in literature. And as with most kind of tools or guidances for older adults, they may not take into account the complexity of each individual with multiple medical conditions and that sort of thing. And then lastly, while I think the non-pharmacologic options are important to consider into a treatment plan, I could foresee how some of the uptake of those non-pharmacologic approaches may vary in practice. So we'll see what happens with that. So just a reminder, the 5 principles still apply. I would recommend for incorporating these into your practice is to kind of go over the table, see kind of what's in there. And then when you're making a particular decision with a particular patient in mind, you can do a little bit deeper dive and link through some of the resources and references. So you can learn it kind of instead of trying to memorize it all in one sitting, you're kind of just spacing it out so you can retain the information a little bit better. The information that's available on the Canadian site, the patient leaflets that are like, you may be at risk, those are free for use, and I might recommend keeping some of the copies of those available. You could hand out to patients and their caregivers when they come to clinics. Use the deprescribing information also that the website I shared with you has a wealth of information. And then ultimately, just a reminder to remember the goal. The goal is not to stop at just avoiding a potentially inappropriate medication, but to come up with a plan that helps people feel better and maintains their health and reduces their risk of medication-associated harms. So with that, I thank you for your attention and would welcome your comments and feedback. And I'm open for questions or comments. I'm actually interested in hearing comments about your perceived limitations of this new tool.